we've grouped our innovations and the new work that we're aware of into a series of 8 buckets, 8 different categories. So the big innovation conversation today is on operational excellence. And this category covers products and services that improve the effectiveness and efficiency of back office non-clinical systems. So recognising that NHS organisations employ lots of people, have to run finance, have to deal with the logistics of moving patients through the system, and all of that needs an element of technology. So this is about products that reduce the running costs of organisations, might address some of the Carter issues. It's about doing the basics really well everywhere, so things like HR, payroll, finance. It helps us reduce variation and duplication in processes, and helps organisations just do things better, faster, safer and cheaper. So these tend to be non-clinical products that just help us do the background work well. We've got 3 great speakers on the line today who are going to share their innovations with you, and you'll be able to grill with some questions. So we've got Graham Bennett from Insource, we've got Mike Cunningham from Healthcare Communications, and we've got Adrian Flowerday from Docobo. So I'm going to pass over to those speakers now. Each of them is going to talk for 10 minutes. Please put your questions in the chat box, and then after Adrian's done his presentation, we'll open it up and have a wider conversation. So first, Graham, can I hand over to you?
Yes, of course. Thanks, Jenny. Okay, good afternoon, everyone. My name is Graham Bennett. I'm founder director of the Insource Group. I'm now responsible for our healthcare strategy and delivery through the north of England. I was very proud to announce earlier in the year we've now opened up our northern office. We're now based at Site at Daresbury, just off the M56 near Warrington, which is enabling us to interact and engage ourselves much closer with our local communities. Most of you will know us as leaders in data automation software and platforms. Many trusts throughout the United Kingdom, including Scotland and Wales, rely on our automated data platforms to transform their operational data into structures that enable them to answer business questions. Now, as I've only got 10 minutes today, I'm going to share with you one of our specific applications, which is called Patient Pathway Plus, and it was designed for healthcare and in conjunction with a number of leading trusts to specifically transform how we manage pathways through from referral right through to discharge through a hospital. So a big challenge for time, so I'll scoot you through at a high level, and clearly if there's any questions at the end, I'll very happily answer them. Now, there's a slight problem with that. That's better. Okay, so what is the challenge that we're striving to address? When we're looking at how patients are managed through a system, once they're referred to a provider, in this setting I'm going to focus specifically on acute services, but exactly the same setting takes place in mental health pathways and community pathways as well. I'm going to focus very much on elective care and referral to treatment targets, so consultant-led activity. But the application is configurable to deal with all elective care, including cancer, mental health and community. What's the challenge we're dealing with? When we're looking at how each provider works through managing patients through their system, we've got a myriad of disconnected systems and processes. The information you need to make an intelligent decision as to what you need to do next in the next stage of treatment usually resides in multiple systems. Currently, most systems are extremely manual and labour-intensive, which clearly is a high cost. Patients at risk of being lost in the system. We found the vast majority of people will work through their waiting list on what's called a patient target list, and that's usually presented in an Excel spreadsheet. When we're managing patients through a system, Excel is probably the most least appropriate technology to ensure that you're not going to lose patients and you actually have a record of what you're doing with them next. There's the work I do at board level, there's clearly a lack of confidence in what is our true open position. Do we absolutely have evidence that we've challenged? Can we demonstrate that our true open position is as we're reporting? It's a concern of many CEOs that I work with, and it's a challenge that we're striving to address. We find also that when we're working with specialties and subspecialties, we find that most people are working slightly different from our standard operating procedures, and their interpretation of what the next rule should be of a clock status when managing through a pathway. We find that there's lots of different interpretations, so we get lots of people doing things differently. We also find that there's an emphasis on validating open pathways and not proactively tracking them. And this is a symptom of data hasn't been entered correctly into our patient administration systems and other operational systems. What the validation is really just going back to our open pathways and checking is what's recorded in the system correct, and quite often that's not the case. So how can we resolve the root cause of the issue and not just deal with the symptom, i.e. validating after a patient has been entered incorrectly? So what is Patient Pathway Plus? Patient Pathway Plus is a central digital administration hub which draws all of the content you require from your diagnostic systems, from your patient administration systems, all the operational systems you need to feed the data into one single unified version of the truth. No longer do we have to go to separate systems to find out what we need to do next. It provides you with a consistent, accurate set of data which enables you to manage all of your elective care pathways. Recently, we've embarked on a consortia which has been led by Cheshire and Wirral Partnership, actually, to use the processing engine to help them manage their mental health pathways. And we're finding some really good results in terms of now adding workflow. So when we have medical secretaries and when we have anybody that's responsible for each element of a pathway, we've now built in a workflow capability that if, for example, you need to speak to a consultant to understand what the clinical next step should be, if somebody hasn't DNA'd, if they haven't attended their appointment twice, we can't just refer back to our GPs, we need to get clinical assurance that's the right course of action. In most settings, what we find is people commit that action to memory, or they put it into their Outlook calendar, or they write it on a post-it note. What we've built into the application is the capability that you can set an action to speak to a particular individual at a particular time on a particular day, which means you have a diary action list, which enables you to proactively manage the patients that you're responsible for. So the key here is rather than having to sift through lots and lots of different data that comes at you from many different areas, you have one list format that presents to you all the information that you're responsible for and enables you to filter down to the cohorts of patients you're responsible for. So it gives you a very elegant environment to work in one system to manage all of your patients through the system. By taking this approach and by having a central unified data set which is updated daily, this eliminates human error. And by eliminating human error, what this means is if somebody enters some information incorrectly, the system will automatically flag up, well, that doesn't look right. That's not what should have been the next course of action, therefore we need to intervene. So it enables you from a management perspective to understand where there are discrepancies, where people may require some additional training, for example, where they may need some additional support in order to process a patient through the system effectively. It absolutely reduces the associated risk to patient safety. I'm sure the vast majority of us on the call today will have some cause to visit a hospital, either ourselves or with a relative, and I, for one, wouldn't be very confident if I knew that I was being managed on an Excel spreadsheet which is disconnected from all sorts of systems. I wouldn't be confident that I would actually receive my procedure in time. Everything is fully automated. It provides you audit trails through everything that moves in the system. You audit that data. What that means is if anybody challenges what is the position with that particular pathway, with no more than 4 clicks of a button, you can see exactly what has happened, why, and what the next actions are. So it gives you complete management control. Now we've got this rich set of data in our system, we can start to do some really quite creative things in terms of how can we learn from history to enable us to predict in the future. So one of the capabilities that we've built into the system is looking at pathways within a specialty that have been treated within timescales. So their first appointment, their diagnosis, and their first definitive treatment has happened within the timescales that we define to be appropriate for that particular pathway. By applying that process to all of the open pathways in that specialty, all of a sudden we can see some outliers. We can see some pathways that haven't received their first appointment within the timescales, and therefore we need to intervene quite quickly to bring them back onto the correct course. So by adding in this intelligence, and of course we're now adding on to, we're doing some work with Salford University to add on top of the data framework some artificial intelligence. Now we've got all of this history that we know is now accurate and is a true representation of our trust position. We can start to do some very creative things with with the information we now collect. Additionally, what this also does for us is when we're looking at demand management and capacity planning, it's currently very difficult in most settings to be able to truly articulate what the demand is coming into any particular specialty or any group of specialties. By having this data managed and being validated as our true position, we can now start to really look creatively at demand management, not just within our own setting, but we can start to look geographically. We've deployed to Salford Royal, who have now deployed to all of the Northern Care Alliance. Patient Pathway Plus is their de facto standard now for managing all of their pathways. And that's giving us lots of opportunity to now look at different trends across different settings within the geographical region. It's really driving value. So we've addressed the first issue, how can we provide the tools and the platform available to our administrative staff to effectively and efficiently move patients through our system. Now we've got all this information collected, which is validated, we can start to ask some very creative systems. The system connects to any source system, and it very much complements individual patient administration systems and EPR systems, and it very much complements the current reporting set that most people have. What this has also done for us is once people are managing their data in an intelligent way through our platforms, we can now start to share content. I don't have time to go into all of the power that delivers, but the concept is very clear and it's now delivering enormous value. If a person in one particular region has some particularly good analysis on some pathways or has some intelligence, they can now share that content with others that are using the system, completely free of charge in our ecosystem of collaboration. It's really transforming how people can now use data, which is probably one of their most valuable resources, to ask some intelligent questions. So what does this mean? It delivers to you, you'll never lose a patient again. I've been involved in many settings where people have felt quite confident their open patient pathway list is complete. When we really run the data through our system, quite frequently we find patients that weren't known before they were run through the system. So we can absolutely commit that now if a patient is in the system, they will never be lost again. That provides absolute board assurance that we now know intelligently, with evidence, what our position is and what we need to do to manage our capacity, manage our demand. It eliminates costly revalidation projects. There's a whole industry that's emerged over the last few years of contract validation staff charging an awful lot of money to revalidate open pathways. If you address the root cause of the issue, if you have confidence that now our patients are being managed intelligently in the digital platform, you eliminate the cost and the need to recruit and retain any temporary validation staff into your system. You can produce all of your national returns and your reports through one click of a button. Within the system, we've collaborated with Microsoft and Salford Royal to create an RTT dashboard and reporting set, which essentially provides you with everything you need to understand your position and operationally manage. That's all provided free of charge within the system. Now we can start to really use our valuable resources to ask some much more advanced questions. Provides you with significant operational efficiencies, and what I've also seen as a byproduct of this, it provides a morale boost to people who are actually involved in managing pathways. I frequently witness people that are very frustrated that they're trying to do the best they possibly can, but the systems are fighting them. By delivering to them a modern system that enables them to do their job with ease, increases morale and efficiency through all of our operational functions. It provides a byproduct of this approach also is that many trusts are going through transitions of moving their patient administration systems and EPR systems and source systems and refreshing them to be more modern versions or indeed different breeds of system. By having patient path connected and deployed, you can provide absolute assurance and confidence that you will always be able to have clarity of your open pathway position and management capability pre, during and post all of your migration of operational systems. So rapidly running out of time, just a few comments of people that have experienced significant benefit in our region here. Emma Wright presented with me jointly at the AFRA conference down in Cardiff 2 weeks ago. The success that they're deriving, and to put into context, Salford Royal have always performed of the achievement of their 92% RTT performance figures. By deploying the system, what they found is they can now actually do better. They don't have to run around at the end of each reporting period to understand where each pathway is. They know that on a daily basis. It's reduced manual efforts, and it's introduced standardization across the whole of the Northern Care Alliance. A very similar approach to Liverpool Women's, who have deployed the system. In the not too distant future, they will be changing their main patient administration system. And what was important to them is they wanted to have absolute accuracy before they go on that journey of migration of systems. And they report back to us that they have absolute confidence and transparency of the system, that they can confidently now move into that migration process. So I think I've just about taken 10 minutes, Jen. If there's any questions, I'll stay online until the end of the session. I hope the content was valuable to you. Thank you, Jen. Over to you.
Fantastic. Thank you, Graham. That was really interesting, and always brilliant to hear about those real life examples about how this has impacted not just on the bottom line of trusts and their processes and the impact on patients, but critically the impact on staff as well. I think is really important. So thank you for that. So now we're going to pass over to our second speaker, Mike Cunningham from Healthcare Communications. Hi, Mike.
Hi, Jen. Is that
Hi?
for you?
Can I
okay?
pass over to you?
Yep. Is that sharing okay?
Yeah.
Okay. Hello, everybody.
That's great. Thank you.
Okay. A quick introduction to Healthcare Communications. We may have a few clients on this call. In relation to patient communications, we process about 12.5 million patient communications a month. Today, we'll probably communicate with about 500,000 patients throughout the UK. We work with over 100 trusts and health boards throughout the UK. And we've internally developed our platforms all out of the Cheshire Riviera down here in Macclesfield, so a northwest success story. Back in December, a global UK-based group called IMI Mobile, who produce all of the for the banks and the utilities, all of the different messaging. They actually acquired the company, which has given us some incredible firepower in respect of what we're looking to do. But from a global context, we thought our numbers were good, but you can obviously see that we're part of a very, very big and successful messaging company. So what do we do? A little bit not dissimilar from when Graham talks about patient pathways. We've looked at patient pathways as well and thought to ourselves, how can we communicate using data already held within PAS and within acute settings, from GP referral to discharge and friends and family test? How do we use data held to communicate at the right time, intelligently, trying to do effective communications at low cost, but also where we can't digitally transact that, give clients the assurance that we can still send a letter, or there may be a more suitable communication channel that's required. So if you look at from referral from GP, whether or not people want to first of all communicate with patients and say, we've got your details, we'll be in touch, etc., to the whole appointment booking process, where we'll show great success that we've had in East Lancashire. The key aspect in that area is we are looking to completely disrupt the letter marketplace and significantly reduce your costs of postal costs. Where we got pre-admission instructions, we can communicate with people to make sure people turn up with taking the right medications. Appointment reminders, we've got, we've been reducing DNA rates within all our client base, anywhere between 20 to 40% for the last, probably about 7 or 8 years. There is options for post-discharge report, again with a variety of different messaging. And we are the leading providers of patient experience and the friends and family test throughout the UK. They're all done through a variety of product modules we have. I'm sure there are callers on here that may have 1 or 2 of those different modules. from ourselves. It all goes through our messaging system, Envoy Messenger. And the key thing that we've done really well is we've not been prescriptive in sort of saying it's got to be digital, it's got to be that. We work with our clients and work out what data you've got. Then we can configure the system to use that data, whether it's email, whether it's mobile, human voice, for specific age groups. Some people feel an agent is more suitable. We've got our own call center here. We've got Portal. Portal really is it's a mobile-friendly web application, and again, we're getting huge success within those. But a key aspect is if those digital transactions don't succeed, we can still provide you with a very, very effective postal letter solution. So it's a real end-to-end solution, and there's just a flavour of our footprint within the Innovate Agency. As you can see, whether it's our Remind product or our Friends and Family Test, we have and the key to this is if anybody's listening, and if we're going to talk about what we've done at East Lancs, we put in the booking element into this. If we've got a system in your trust, then we've got a connection into our software. What we talk about today can be achieved very, very quickly. The problem we're looking to solve, I don't know if anybody looks at this and chuckles. The company's 18 years old, and you know, this problem still existed all throughout those years. The numbers just keep getting bigger and bigger. So it's about outpatient efficiency, really. And a key aspect of that we established was, as much as we can do reminders and DNAs and stuff, there was a big aspect in letter-related problems as well, with letters arriving too late, not being received, being lost. And I'll put my hand up now and say I do fall into a category of patient that does leave post unopened as well. And we are so we're getting into some of the key sort of detail as to why some of these problems are occurring. We went live, it's about 18 months ago, with our first digital patient portal in Barnsley. And we did a follow-up survey, independent in respect of that. And a key aspect was that it's also important to, as much as we talk about digital first, but patients are consumers, and how do people prefer to be communicated now? You know, over 68% were happy to receive notifications via text to the phone. And, you know, again, on the call, you know, 57% have already gone paperless in other call correspondence. And the Barnsley stats from receiving a text message inviting you to use a PIN to log into the patient portal, we kept it, we've made it secure, but we've made it quite user-friendly. We're now getting over 50% of patients choosing to log into the portal to receive their, look at their digital communications rather than receiving a postal letter. We're very proud of what we've done at East Lancs, and as much as I hear the Salford Trust and what they do there is fantastic, but it's not all about Salford in respect of our region. And we've got a real digital leader in East Lancs regarding the digital case study we put together. What do they want to do? They wanted to build confidence in patients who are receiving communications from the hospital. Let's not lose anybody. They wanted to digitize the touch points. They wanted to make it easy, improve accessibility. And a key thing in what we do is we deliver efficiencies, but we will deliver that cost saving for you. So the easy bit of putting the appointment reminders in, we've reduced their DNAs from 8.9 to 7.1%. And as much as there's so much noise about digitization, there is still a very, very straightforward gain in having an effective low-cost reminder solution. This was just using SMS IVM, which is human voice, and they chose for patients over the age of 75 to use an agent call because it was felt that it was appropriate. And in respect of the two-way opportunities within that, we generally deliver about 4% of the appointments back in as cancels and rebooks to be reutilized, and that translated to within this period, quarter 4, 16-17, we've delivered 38,000 reusable slots for them. And again, from a PBR point of view, on a 20% reduction rate, it translates to cash. Kickstart your digital journey. This is just a view of what it looks like. So on the right-hand side, people will receive a text message if you've got a mobile number. And in simple terms, it's got a secure URL link, a PIN. People go to, it's mobile friendly, we'll put their date of birth in, and they're into the portal. They're looking at the letter. We're getting over 50% of patients choosing to do that. In simple terms, if we do that for you, there's no need to send a letter. Where patients don't log in, we'll work to your standard operating procedures, and if it's 24 or 48 hours, we'll deliver them a letter. And obviously, where there isn't data there for a mobile transaction, we will send them a letter. There's a lot of noise about what's a portal. We built a portal without the medical interactions, keeping it simple, because we wanted to look at the patient communications aspect of stuff. So within our portal, there are past and future appointments. People can cancel, rebook. The plans are to make that interoperable via FHIR and HL7. A lot of noise about that at the moment. Not many people doing it. So those interactions at the moment would go back to booking staff to look at those. We include all attachments and directions within the portal. The maps are being very, very widely used. You can put the digital assessments and surveys within there, and then what's highlighted in amber, if you like, is stuff that we're watching. There's a lot of talk about video consultations, obviously a few things about tariffs up in the air, but we feel that will come into there. And we can also integrate iChat and bots into there where you can have conversational transactions taking place from the portal to people in the booking centres. Access-wise, we're over 50% now when we launched. There's not many. There aren't any other portals generating these type of login rates in respect of that, and we're getting a really good age range as well, which we can provide further stats of as to who's coming in. What's it delivered? Well, the key aspect in what we've done is we are reducing the cost, the postal cost within East Lancs by 50%. We're taking about 250 grand out a year. And this went live in June 2018, so it's cash releasing from the moment it goes live. And part of what we're saying is going to market. We're on NHS SBS CARAS 2 framework, G-Cloud 10. You know, this can be procured and implemented in a short space of time. Sorry to do that to you. There's a few photos. There's a photo of me, but my team. We're very, very proud. We've been doing this 18 years, but last week we won a significant prize at the Excellence in Supply Awards in Manchester. And as much as we were doing this 18 years, this is probably the 5th iteration of products that we've had. And it was a great validation that what we're doing is still very much in line with what our clients are requesting. So to summarise, we do look at digital first, but we give the assurance that we can still communicate with non-digital patients. Trusted supplier, we tick all the boxes in respect to those procurement frameworks. Implementation between 4 and 12 weeks. Immediate cash releasing. Standard reduction of DNAs of 20 to 35% that shouldn't be discounted. We can increase appointment utilization. We can improve patient access and experience. And with the acquisition that occurred to us, we are so future-proofed in respect of AI and chatbot opportunity to make those booking centres and those patient journeys and pathways automated. It's a very strong roadmap to the technology that we have available to us. I hope that's 10 minutes. Is that
Fab? Thanks.
Is that,
Yeah, that was really interesting. I'm fascinated by these tools that kind of give patients more control over the process. And I hear what that last point you made about digital first, but not forgetting the other channels. And I think there's a great opportunity for us in the NHS to take advantage of the people who want a shift to digital in how they engage with health services, and still allowing those people who for who that's not going to be right for a number of reasons, to be able to go through the paper-based, face-to-face, telephone. I think it's absolutely within our gift to have both channels.
Yeah.
So really, really interested to hear about your work.
Thanks, Sarah.
So now our next and final speaker, Adrian. Adrian Flowerday from Docobo. We're just seeing his slides come up now. Adrian, you on the line?
Yep, can you hear me?
Fab, yeah, absolutely. I'll hand over to you.
Okay, lovely. Hopefully the slides are up there now, so thank you. Hello everyone, thanks for dialing in. So our world is around kind of digital health, and we're kind of in the northwest. We have a kind of fairly large contract with Liverpool, CCG, rolling out telehealth, remote monitoring, and some of our population health, and then the Lancashire test bed are involved there as well. So kind of stuff happening up in the northwest, and hopefully some in Tameside and Glossop coming on. So today's talk really is about how we can use some of those solutions to improve kind of operational work rather than say the clinical stuff there. So if I go into kind of what we're about really, we're about kind of intelligence, knowledge, decisions. We have two systems really. One is a population health system that allows us to collect a whole load of data around hospital, GP, mental health, social care, looking at utilization, costs, predictive risk, diagnosis, medications, and the like. We then blend that data and we allow commissioners, ICS leads, STPs, GPs to be able to use that data to understand the problems, understand their prevalences, understand trends, to be able to identify cohorts of patients that need particular interventions, to understand costs in the system and the like. So, and then we have technologies to allow people to be monitored at home in a whole load of different ways of reaching out to them. And then because we're tracking this data monthly, we can then track return on investment of any intervention that is put in place with our population health system. So that's a quick overview. If I go to the next page, a little kind of techie, if you like. So we have these two solutions. One is called Artemis, which comes from Greek god of the hunt. It's about hunting for patients, hunting for costs. And that's the one that takes a range of data in from those various sources there, hospital, GP, community, etc. And that allows clinical teams to be able to identify, track patients, their costs, risks, trends. We have a load of predictive tools in there that allow us to predict future utilization within the system. That helpfully finds patients, identifies cohorts of patients that perhaps some home monitoring, home technology can be useful for. And that's the other side of our business called Doc at Home, which has really been running probably in the UK for about 10, 11, 12 years, where we're collecting data from patients in their own homes, particularly the elderly, poorly symptomatic patients, and collecting data from them. And we have a range of what we call interaction options that depend mainly on technical and cognitive ability of the patient in order to collect that data. So it could be apps on tablets, smartphones, it could be web-based, or it could be via a very fit-for-purpose device that we supply that is very much designed with the help of Age UK for elderly people to be able to use and collect data. So we can collect that data, and then clinical staff, particularly, there typically is a hub of nurses tracking that data, looking at alerts and managing those patients remotely and the like. So they're the two things we do. So I thought if I kind of show you, why is it not going to the next page? Let me just work this out. That's better. Right. So Artemis is our population health solution, and it consists of three layers really, which is unique in what we do on population health, where we stratify across a population, so we can tell you everything about your population, again from kind of STP, ICS level right down to GP level. From there, and the filters in there that allow you to identify cohorts of patients, you can then drill down to what we call a cohort analysis that allows you to see those patients, see a whole load of conditions that they've got. So if you're looking at kind of putting people on certain pathways, you can understand all the different comorbidities that patient would be experiencing, so you can put in the right type of multidisciplinary team intervention. And then you can drill right down to individual patients and look at particular things about particular patients, so you can understand the integrated care needs of that individual. So a few screens just to show you what that looks like. And to give you a clue, one question a commissioner may have, what are my patients costing me? So we can stratify it into the different risks, admission of A&E, attendance risk scores there in the different colours. You can see how many GP contacts, outpatient appointments, etc., community contacts, social care, and the cost of those contacts on that. On the right-hand side, you can filter down to any type of group or cohort. So you can say, right, give me all my patients with COPD costing me more than £4,000 a year, who have also got mild dementia and have got heart failure. Bang, we'll give you that numbers of patients in the main view. So you can very quickly find cohorts of patients. This type of thing typically takes rows and rows of CCG staff collating information from endless sources into Excel spreadsheets and trying to understand them. Here you can do it at a click of a button. And anywhere there's numbers there, you can drill down to those numbers and find that those particular patients who are making up that 27 very high-risk patients, if you like. So a very quick kind of way of seeing where your costs are. Another question is, well, how well are we doing delivering care? So an example here is diabetes. How well are we delivering diabetic care against NICE guidelines? And what this allows you to do is very quickly see how well you're delivering that care against those NICE guidelines, whether it be health advice, monitoring exams, monitoring measurements, and the like. And the beauty is it allows at a CCG level to be able to identify which practices are doing better at something and which practices are perhaps need some help to be brought up. And that way you can focus your resources rather than doing a diabetic service across a whole region that's not needed, where some places are actually good already. The next slide is drill down to a cohort, and it just gives you a hint of looking at that patient list and who those patients are. You can see their frailty score, which is the indication of how frail they are, their CPM risk score, and then you can see whether they should be on the end-of-life register and what type of conditions they've got, or long-term conditions. And the bottom view is a view of the last 3 or 4 years, is what I call it the DNA chart, but it's all the activity that individual patients have had. So that when you look into whether people should be on multidisciplinary teams or on healthcare coaching or navigation, you can look at which patients are more suited to those particular interventions. The next view is another view where actually, some people, they say, right, well, this year we're looking at the high-risk patients, and next year we're looking at the high-frailty patients. Well, actually, what you need to look at is combinations of those different groups and find out who are the frail, high cost, and very high cost. So we use a whole load of Venn diagrams to help you understand where are the really poorly ones who sit in the middle, that 587 patients who are very high risk, very frail, and high cost. And then you can start looking at them and putting in proper interventions into those groups. And again, this is just hints from the screenshots we get from the web system. Following scenario cost planning, you need to work out a business case within our population of our disease groups and our costs. If we put in an intervention, how much will it save? So we can develop our business cases and understand prediction of how much savings we're going to make. And then we can track those savings and understand if we've made those savings. Next slide, has my intervention made a difference? So we've put some intervention in, we've commissioned a service. At the moment, generally the NHS doesn't really know whether it's made a difference to those things. So what we can do here, you can select which patients are receiving the intervention in Artemis, and then you can look at how much difference that's made 365 days before you gave that intervention to that patient or that group of patients, and then 365 days after. And you can start understanding whole system cost changes as opposed to just costing one part of secondary care or like, because what you'll see is things move, and some people, there may be more cost in community, but less cost in acute, etc. That gives you a really good flavour of that. So kind of overview around that really is you're looking from a population to a cohort to an individual, and it allows you to kind of go around that circle of identifying prevalence, costs, identify cohorts. You then identify integrated care needs of individuals at the bottom, and allows us to support from cradle to grave of a person's life. And then we can track outcomes. And what it enables you to do, if people are bold enough, and we'd love to talk to a CCG about this, is around automated commissioning. We can see the gaps in care. If we know what provision is needed for those gaps, that could be auto-commissioned as opposed to a very big, long 5-year contract need to put in place. So it can make very very agile commissioning from the system. So finally, to really kind of give a flavour of what opportunities are there within that for operational excellence. Well, Artemis, certainly things we're seeing, reduce staff time to find that intelligence, so to find data, to find cohorts, etc., to find prevalence, gaps in care. And we've seen things like 30 to 40% staff reduction times in being able to find that data. So what it means is you can reallocate staff from collecting data to being involved in delivering care and organising care delivery. So therefore, you can focus resources only on areas of need, not across a whole patch. You can identify the right patients for the right interventions, and what that means is you improve your return on investments. And an example there, telehealth was given years ago, but it's all given to the wrong patients, so therefore you never saw the return on investment. So it's identifying the right patients. The other thing you do, because you know about all the medicines people are getting, you can optimize, you can move people onto generic drugs. You can say, right, actually, do these patients need all these drugs? Let's go in and find patients on, say, more than 10 different drugs. And for Docobo remote monitoring, what it means for community teams, and typically there's massive vacancies in community nursing because we just can't get the nurses. They're overloaded, stretched, feel they go home worried about their patients. Well, now they only need to visit by exception, which means we monitor, and only when a patient goes downhill a bit does the community nurse need to visit, as opposed to visiting every week. So therefore, they can know their patients are all okay, that they're looking after the ones who need them. It increases their caseload, so that increases efficiency there. Reduce 999 conveyancing. We can track things before they end up calling 999 and then A&E. Virtual outpatients allows us to actually do a lot of kind of outpatient mundane stuff by just using the technology to reach out to patients rather than coming in for 10 minutes, having to park, wait to see the consultant, get asked a couple of questions. How are you? How's the wound? Are you doing all right? Yeah, fine. Can I go home? Yeah. So do that remotely, do it with technology and reduce length of stay. And just finally, we sit on the London Procurement Partnership framework, G-Cloud, and just the recently launched NHS England health systems frameworks. And I think that's it. Thank you.
That's brilliant. Thank you, Adrian. Really interesting to hear about a different kind of system that looks at a different type of patient flow through the system. So thank you very much for sharing that. So we've got about 10 minutes for questions. So as we mentioned at the start of the chat, if you have any questions, put them in the chat box or raise your hand and we'll unmute you. I'm sure people are digesting what they've heard. So to give people a chance to reflect and think about what questions they might want to ask, I'm going to use and ask a question to all three speakers. Just to think about, it's great to hear about the solutions that you've developed, and I think all of you touched on this a little bit, but interested on how you've worked with teams to change the processes alongside the technological implementation. So what's your experience of that in terms of what does and what doesn't work in terms of the human tech interface? Who wants to take that one first?
I'll happily go first, Jen, if you'd like me to. It's Graham here.
Thanks, Graham.
In my experience through healthcare, which now stretches 24 years, the challenge in front of us is everybody is very, very busy trying to do the best they possibly can. And to be frank, the last thing they want is change. So the key to success is working with people to make sure any technology is of value to them, which helps them do their job efficiently, and change isn't viewed as a threat, it's viewed as a help, going back to help them manage their patients through systems much more efficiently. We invest an awful lot of time with our operational staff to ensure they're supported, their views are understood, and their requirements are understood. So what they actually get back is a very simple system that helps them do their job more efficiently. And it's taking the barriers away that technology is to be feared. Technology touches everybody's life, inside work and outside work. So it's just making that work best for them so that it makes a positive change. And I think it's a real critical success factor of pretty much every solution we've been involved in.
Brilliant. Thank you, Graham. Adrian, Mike, anything to add to that?
Real life examples, this Mike from healthcare. Just echoing that fear of change, etc. Where we've implemented systems, booking teams can sometimes be a little bit threatened by it. But once we do the training, they recognise that the messaging system, for example, can actually, where an appointment needs to be cancelled, it can also automatically cancel those appointments. If they're looking to refill the rebooks and cancels, instead of making 20 phone calls, they're using our system to send an invitation out to 10 people up near an RTT list, and they call back in. So it's breaking down those threats and actually showing how the technology can be an enabler. In patient experience, we had a huge amount of admin going on in relation to the collation of friends and family test. Again, we automated that with digital communications, and all of the information coming back in was analysed and stuff, and the patient experience managers are looking at what improvements they can make from the feedback rather than that whole collation and admin piece.
It's Adrian here. Thanks, Jennifer. I think, from our point of view, it has been around change management and managing that at the clinician end, particularly with nurses, particularly around telehealth. And quite often people find money to buy stuff, but they don't put in the resources for that change management and allow time for that to happen. In Sussex, where we've implemented a big telehealth program, a lot of our time is with nurses, and our staff have been out with every nurse event, buying them sandwiches, talking to them how they can improve their CV, how they can reduce their stress, and feel they're overloaded all the time. And now a lot of those nurses who are perhaps the most negative are now our best advocates, because they don't just get it. But it's a 2-year program to change hearts and minds to get around to doing that. So from I need to see my patient to actually I don't need to see them. They'll be much better monitored, and I'll go and see them when they go downhill. And for nurse, what she realises actually her experience is improved in her clinical experience because she's dealing with more complex cases rather than her experience in understanding the traffic lights and the sequences to get to the house every week. So it really improves their CVs, which have been really good. I think on the Artemis side, it's been working with practice managers, with GP federations, and helping them understand and quickly get to understand what their loads are of patients coming to their clinics, of what they're doing and how they're managing them, and also the information that they're given about that patient that they didn't know when they came into the clinic. So that's been really good, and we certainly have to put a load of kind of insight time to supply insight about what the technology and the data is showing them, to kind of take them on that journey. But it does need, I always say it needs a commissioner for change in every CCG, who's actually got a budget to allow things to do change, because they're so stretched in doing their day-to-day work that it's very hard for the clinicians and the local managers to change things, because they're so fixed on what they're doing. So it's really important that resource is made available to enable change.
Fab. Thank you. A really, really fascinating trot through 3 really interesting tools and then the implications they have for staff and patients. I'm proposing we close it there. I hope that's been really useful to everyone. A recording of this is going to go onto our website along with all the other big innovation conversations, and you will receive a link to that. I know we generally get really good download rates for these conversations, so if you want to go back and check anything, do go and do that. And we look forward to seeing you on the next WebEx. Take care, everyone. Thank you.